Now, answers are going to determine the treatment targets and help you decide on initial interventions, which can be timed based on whether a factor is more of an immediate or remote cause, or as many of us also conceptualize, predisposing, precipitating, or maintaining the sexual disorder. Explaining the STP, though, and treatment targets not only provides hope, though, but actually begins the recovery process by reframing patients' cognitions. So where do you begin? Dr. Kaplan Helen conceptualized the issue starting with the more immediate psychological causes, ones that are currently maintaining the problem. So how might you determine that? Sometimes it's just brief education. That's all that's needed to assist the patient or partner. I'm not going to read this whole thing, but essentially a 60-year-old man came to see me who was a marathon runner. He had hurt his Achilles and he was no longer running marathons, but he had developed erectile dysfunction and had continued exercising, even though he wasn't running marathons, essentially every morning for about 5 miles. So in our very first session, I complimented him on his regimen and good health, but I asked what his thought might be about his sex life if he cut the running time back to 2 miles, perhaps 3 times a week, and slept in later on the other 4 days. He laughed and he said he'd give it some thought. We continued the evaluation and we scheduled a follow-up session to complete the evaluation. Well, he canceled 6 days later and left me a message that he was running less frequently and for shorter distances. But he had already had 2 successful intercourse experiences with his wife, and they were both thrilled. Now, fortunately, the surgeon who referred him to me for pre-surgical clearance for the penile prosthesis he'd been planning on putting in continued to refer to me subsequently. So treatment begins with the first contact with the therapist, as all is an opportunity for teachable moments. Sex therapists will offer a suggestion, typically a homework assignment, if you will, such as sensate focus or self-exploration, stop-start for premature ejaculation, etc. Pharmaceuticals can also act as a therapeutic probe, but detailed examination of those experiences or a person's failure to act on your recommendations at follow-up sessions will reveal the initial causes of potential treatment failure, whether they're current and superficial, like, oh, we didn't have time, or relationship and or deeper issues, which may require a more in-depth intervention and greater time for the treatment. But as a therapist, you want to just pivot and adjust the timing of your interventions according to the pushback you're receiving from the patient. The psychoanalysts used to refer to this as resistance. And that can be conscious or unconscious. Continuously reassess, though, and vary your delivery to the unique way and manner your patients can absorb this. So at the simplest level, use our language. If they're saying, fucking, then you're using that word, you're not saying coitus. If they're more intellectual in their speech, then and they're talking about cunnilingus as opposed to oral sex, then you're going to use their words. It just helps people feel more comfortable. It helps you establish more rapid rapport, and they're more likely to hear what you have to say. Now, at every session, I try and get a sex status as a follow-up where I'm exploring the most recent sexual experience they had, whether it was something they decided to do on their own or something that I suggested that I wanted to see what the result was. If one of their physicians has prescribed a sexual pharmaceutical, you want to assess how was it used? Was it used properly? These are things you want to educate yourself about so that you're able to interact with your colleagues. I'll talk a little bit more about the importance of an integrated treatment, a transdisciplinary treatment, if you will, in terms of what you need to know to be able to provide the most help. What about weaning and relapse prevention, especially when it comes to medication, as well as the frequency of the therapy visits themselves? So using this STP approach, patients may be weaned from their drug or their medication can be reduced, further improving a risk-reward ratio, because we know so many of these drugs, the treatment effects are dose-related, but the adverse events, the side effects, are also dose-related. So if they can use yet less of the drug and still have a good impact, a good effect, obviously that's preferable. However, when greater illness or stress changes the sexual tipping point, more medication or coaching may be added to the equation. So I'll teach patients before they have terminated that while they may have weaned themselves from using one of the PD5s, for instance, for erectile dysfunction, or they're taking a much smaller dose, that if they're under a lot more stress at work or something else is really disturbing them, but they're interested in having a sexual experience anyway, that they can go back and use a little bit of a larger dose. In much the same way, you don't take aspirin every day to make sure that you are prophylactically preventing a headache. You typically would use something like that for pain relief once you had a headache. So if you can anticipate that a little bit, a little prodromal sensitivity, sensation, um, you take the medication. And in the same way, if you're feeling really stressed but you want to have sex anyway, as just part of the intimacy you're looking for and to just enjoy life, then by all means, adding a higher dose of medication on a temporary basis and then go back with a new equilibrium later.